So today with Rosslyn Bentley, the Executive Director of Woolwich Community Health Centre located in St. Jacobs in the Waterloo region. How are you today?
I'm great. Thanks for asking. How are you?
Wonderful, thank you. Please start off by telling us a bit about Woolwich Community Health Centre, the clients that you serve and the services that you provide.
Yeah, so the Woolwich Community Health Centre began in 1983. If anybody knows this sort of beautiful part of rural Ontario, St. Jacobs is Mennonite country, so we are beautiful rolling farmland just north of the urban conurbation, and at that time it was still very, very bucolic. It's now much more ex-urban, as we like to say, really close to the University of Waterloo and the sort of technology hub. About 40% of local industry is agribusiness. So it's not just farming, it's all the food industries and other kinds of associated services working with the agricultural industry. So it's an amazing crossover, modern Canada at work. So the Community Health Centre here was established to look after the health services. A lot of local folks were finding it difficult to access. We have a fairly large old order Mennonite and Amish population here, so horse and buggy Mennonites. So these are folks who wear plain clothes, who use a horse and buggy to get around. So obviously modern public transit is not accessible to them. Parking your horse next to the kind of traffic that we experience in the modern era is not great. And many old order do not accept the provincial insurance. So even though they're eligible, they do not like to rely on public resources. They are very humble people and they would not like to be receiving services that may require some reciprocity with regard to public education of the children or to be conscripted at times of warfare. So if you look at the history of the Mennonites, there are migration patterns that are related to avoiding those. They're pacifists, Christ-like in their work, and they do not wish to be forced in those situations. So part of their typical work practices are to remain in a humble way and not receive public services. But of course, they still have healthcare needs. So there's a lot of self-doctoring, naturopathy that go on. People like to dose themselves and look after themselves at home, but there is increasing opportunities for them to receive services, and that's been part of what we've been doing. So the Ministry of Health funding started to flow in 1989, and we built a health centre initially in downtown St. Jacobs, but later in 1995, a 3,300 square foot facility in St. Jacobs. And then we expanded again with a midwifery service. In 1999, we created a new building next door at 9 Parkside Drive that also accommodates a naturopath and midwifery practice. We added physiotherapy services and a nurse practitioner office in a small rural community, Linwood, about 20 minutes north of the location here in St. Jacobs. And then Wellesley Clinic opened in 2005, and we've just heard news at the beginning of May this year that we're going to be able to move to a new clinic that will be attached to the Wellesley Township recreational services that are being redeveloped. So there's a new recreation, gym, senior centre, youth centre, walking tracks. So lots of health promotion and prevention activities in a building with a new health centre attached that will be right-sized for the size of team that we already have, because we're currently in a renovated older building. It's about 80 years old, and although it's reasonably accessible, it's not up to modern standards, and we certainly experienced some challenges during COVID. Those initial keeping 6 feet distance from other people, in and outflows in the building, so there were no cross pathways for infection control. Impossible to do in that space. So we're really pleased to see that we're going to be able to grow in a new community.
That's so exciting. Congratulations. Definitely sounds very needed, and I'm very glad to hear that. And I might have to have you back on the Community Matters podcast to just discuss more about what you guys will be doing with that expansion. We know that Ontario is very fortunate to have a large number of community health centres that receive core funding, not just from the provincial government, but also some other funding from federal and municipal governments as well. I know you mentioned the very unique community that you do serve, but I'm curious if you still see gaps in terms of individuals or groups that don't have access that would benefit from access to a community health centre should you have increased funding.
Absolutely. Well, of course, we would say within the Anabaptist communities, so that's Mennonite and Amish, particularly here, these are folks who tend to have larger families, and we don't have enough capacity to take on all the family members. So we have an increasing number of unattached patients. And although we try to prioritize our rural community patients, there is an increase within the Waterloo region of unattached patients generally. So just general care for everyone, we would say, is probably our highest priority. But we also see new Canadians. This is an area of agricultural work, as I mentioned earlier, so that can often be attractive to people new to Canada. We have our, obviously, transitional folks who come for seasonal work, although this is not as big a region as the Chatham-Kent area where the tobacco fields and the big greenhouses are. We're more, smaller greenhouses and apple orchards here, but that still attracts seasonal workers, and they tend to have poor connections to healthcare. And then, of course, the underhoused and the chronic mental health population. Anybody with complex health needs really struggles in the rural communities. Everything's so far flung. The internet connection can be really poor if you're lucky enough to even have accessibility to technology, or if you're comfortable in using it. I mean, that's another barrier for the Anabaptist communities, is the more conservative do not embrace technology, and so we have to find ways that are acceptable to them. So there are many people experiencing barriers. We'd just like to be able to alleviate some of those barriers to have them be attached to primary care providers.
You spoke previously about the pandemic and a little bit about how it affected you with the spacing issue. And we know the pandemic was difficult for so many community health centers to adapt to continue to meet the needs of their clients, yet they all seemed to persevere. Can you speak to the impact specifically that Woolwich Community Health Centre made over the past 2.5, probably more now than 2.5 years of the pandemic?
Well, I guess I wanted to sort of recognize the new bywords in healthcare: virtual care, pivot, and hybrid. I think these are our new watchwords, right? So we moved to a high percentage of virtual care, some of it very low tech, using the phone, but we had very high technology usage and increasing in the populations that were comfortable doing that. So at the beginning of COVID, we certainly had as high as 80% of our primary care visits were taking place virtually. We had already invested in up-to-date technology. We were heavy users of the Ontario Telehealth Network, as well as having TELUS PS Suites and the supporting technology. We've been lucky enough to access provincial, federal, and local township grants and donations to set up technology libraries so that we can lend tablets and cell phones with data plans to local people. So where there is reception, we do provide support to some of those high-risk populations. So we did also make lists of our high-risk patients and call them warm line supports to make sure they were hooked up to other supports, how they would like that. And I think, part of the trusted relationships is also about making sure that we tailor what we offer to people so that they got the kinds of supports they wanted. So, some frail elderly people were getting like 10 calls a day from different agencies, Meals on Wheels, with transportation, family, and then other people getting no support whatsoever. So we just made sure that we were all connected to make sure nobody fell in between the cracks if we could. And that's the beauty of rural neighbours. People do that. But we also targeted many sort of high-risk activities, expanding vaccine access, initially COVID testing. We worked with the local public health unit and our OHT to create a mobile testing service initially. A lot of Mennonite people were very hesitant around vaccination. They were also, when they were sick, unable to get lifts. There's no Uber out in the community, but they do rent cars for getting to high distance appointments and those kinds of things, because they're horse and buggy normally. And to get to medical appointments, those drivers were either sick themselves or didn't want to carry people that had symptoms. So we went out to them. We worked with a local bus company and one of our nurse practitioners. With some of our nurses went out and did testing in the community. And then as the vaccines came along, some of that mobile service morphed to public health nurses going out to provide vaccines in a very low-key way, unmarked cars, not in uniform. It was very important to people to preserve their privacy. The choice of being vaccinated was quite controversial for many people. Public health, for example, also offered local city buses in market days and in popular locations, so that people could just pop in and get a vaccine on a day when they might be in town for shopping reasons or for being at the market selling their cattle. And then in low-key locations where people wanted privacy, they didn't want the neighbours. I mean, we even had family members, you know, the wife would come in one day for a well woman checkup and get a vaccine, and the husband would come in another day for another kind of checkup. People didn't necessarily want their own family members to know. That's how difficult it was for the stigma of accepting vaccinations and the degree of hesitancy. So we were certainly very, very involved in providing education, myth busting. We used a WhatsApp group that we had a peer worker provide support to. We used some of our nurse practitioners to go out to rural workplaces and give targeted speeches to a lot of rumours, for example, around fertility. It was very important in this population. So, you know, addressing some of those specific questions was very attenuated to that local cultural situation. We also worked to provide you know, a lot of flexibility as every wave of the disease changed and the precautions changed. You know, we adjusted our approaches and we stayed on the sort of more conservative side to not have to keep sending out, you know, daily updates, because although the word of mouth system works very well locally, we of course still have lots of people who are not Mennonite and do rely on technology and keeping them up to date. We launched a wellness blog on our website, and we certainly tried our best to offer services in languages that were appropriate for our local community, like Low German and Plattdeutsch. So we did offer about 1,800 vaccines across our clinics between October and the present time, and that seems fairly low in some respects, because before that we were working in the rural community with a lot of political and community pressure to offer sort of pop-up clinics rurally. We resisted that and said it was more important for all the different styles of rural practice to work together because there's so few practitioners. So we actually worked with the local family health team, a FO in Elmira as well, and all of us sent our primary care providers, physicians and nurse practitioners and any nursing staff that were available as well, to provide support in a central rural location. And we were able to get up over 14,000 local rural vaccinations, which in the Waterloo region is really significant because a lot of people don't have access to public transit or can, because of their workforce or their ability to drive, get to some of the big regional centres. So it was really significant, and every single model of practice was involved. So we're really pleased to be part of the leadership in that response. The other thing that we really are very grateful for was some very coordinated work with the local community living. We have several units locally, and we were able to go on site and vaccinate all of the staff and the residents. So that made a huge difference, because there was a very big COVID outbreak at the beginning, and that was a very vulnerable population. So, you know, we did over 180 vaccines on one day, for example. We had 4 vaccinators go on site in December and give third dosage to some of the highest needs clients and the staff. And that really put them in good stead for the Omicron response. So that was part of our regular ongoing care to that group, but it was done in a coordinated way. So it just meant that they got their care very early in the recommended dosage. So we obviously provide ongoing support. Another thing that we did was, you know, adapt. About 40% of our staff continue to work in a hybrid way. Counselling, mental health supports was 100% virtual for a long time, and we're still at about 75% because we actually found our clients preferred it. A lot of young people particularly are able to text and attend appropriate appointments with the privacy of their phones in different circumstances. Of course, the opposite can also be true, but it's given us a lot more flexibility, and we have much less, you know, dropped appointments. So people, even if they're not feeling 100% that day, might still be able to attend virtually. So we don't lose all of those appointments that get lost to bad weather, or they've lost their ride into the appointment and that kind of thing. So those have improved as well. And the average number of people attending our health education events has increased. Back in April 2019, our average number of attendees per group was about 7, because the physical spaces that we have to have meetings are pretty small, and the travel distances for people. So that was pretty average. Now it's 17. So it's considerably more people are able to attend. And when we run really interesting and push out the information, the topics can get picked up outside of province even. We've had people from Saskatchewan, Nova Scotia. We're aligned with a local Woolwich Healthy Communities group that does a lot of environmental education, and they ran a talk about some trees and local planting to improve the environment, and we have people from the States attending. So, you know, the reach of the education has really increased. So we're excited about that and to maintain that in the longer term.
That was such a lovely snapshot of everything a community health center is capable of, like from pandemic. I started this job about it almost a year ago to the date, and so I've seen like how the front lines were a very stressful, difficult place to work with a lot of burnout, but that story was so inspiring to go from like obviously very difficult, giving out as many vaccines as you could, going into the community, but then also, you know, that virtual care and lowering those like digital barriers for some groups of people, allowing for even people in the United States to participate with some of the programs that you're doing that's very awesome. So my final question, and that snapshot honestly was perfect to express what your community health center does and all of the programs that you have. Do you see particular areas where increased federal investment in community health centers would enable you to increase your reach and further improve health and well-being in your community and potentially apparently beyond?
Yeah, absolutely. I mean, I think I already mentioned, and I know it's really at the provincial level that this, you know, the rubber hits the road, but overall the importance of access to primary care. There are more and more unattached patients in Ontario, and as physicians age out, there are more and more healthcare providers who are sort of COVID exhausted. So people are leaving the profession. They're not able to take on the size of workloads. You know, mental health is increasing enormously. So the amount of, you know, more personalized support that people need is increasing. So we need to promote self-care. for both the public and healthcare professionals, healthy lifestyles and resilience in strong communities. So, one of the joys of living rurally is that you can see some of those benefits. People are very clannish, they have their faith community, so the sort of existential supports that really sustain people and provide resilience are there, so you see that. But then they don't necessarily have access to the education and technology that would also further those benefits that they have. So we'd love to, really emphasize the importance of big picture thinking and long-term investment. We want to be able to see healthcare providers from the peer sort of career pipeline developed, so that there is a strong promotion of equity and diversity and inclusion. Obviously in this community, the Mennonite community is white, Christian, but we have an increasing diversity from the BIPOC community and a hidden Indigenous community. When we looked at our census data a few years ago, there was a remark made, oh, well, there won't be anybody here. And in a very small community, there were 5 Inuit self-identified in the recent census. So, somewhere out there are Indigenous communities that are just not being served effectively by us. So greater knowledge, training and cultural humility by our team, and then really, deconstructing the racism within our healthcare systems. These are all efforts that are being currently supported, but we appreciate increased supports to really do that as part of the training and the ongoing supports for our staff. We want to disaggregate the race, ethnicity and language data that we do have. We've been finding that we haven't made enough efforts to do that, so it takes staffing to do that, and maintain that effectively, and to drill down so that we can actually measure the impact of the work that we're doing. And I just have a great quote from one of my nurse practitioners years ago. She said, I'm tired of prescribing pills for poverty, which I thought was a great encapsulation. We want to hit things like housing. Access to low-cost, accessible housing is a real challenge in this region, as it is everywhere in Canada. But housing prices in this region are going through the roof. And because it's this borderline rural area, there are, even within our communities, the price of farmland is driving people beyond our borders to other areas. So there's a great deal of transition, and any chance that we can have to, offer young people hope to stay in this community would be really helpful, so that we can provide ongoing supports for them and have intergenerational relationships instead of this more sort of bedroom community emergence that tends to be dominating these rural hinterlands. And then finally, mental health. How could I not say that? We've got some mental health supports, but it is not across the full continuum rurally. There has been an emergence at the provincial level of some farming family supports that have been really good, but we need those peer developments that have been successful, decade-long processes in other communities. We just had a mental health planning day with a lot of rural partners earlier this week, including the police, which is the only area locally where there's $10 million worth of investment in police response to mental health calls. And we want to make sure that some of that comes rurally, but we also want to educate people that the police force is not trained in health and social effectiveness. I mean, they do amazingly well and we do support them, but this is a very expensive blunt instrument to respond to the kinds of chronic mental health issues that we're seeing emerge. So we can do more health promotion and prevention upstream, earlier interventions with young people, with families at the early stage of identification, but also just the systemic issues, anything that we can do as a health centre to provide education and spread the word about what some of those things are. And peer outreach, I just can't emphasize that enough. Creating that recruitment opportunities for people from the community, so that research is done from within the community to provide best practices. Those are the kinds of insights and effective programming that really stand the test of time. And so when we get things in a periodic, piecemeal way, that does not promote trust that these things are going to be around another day. And so people are very hesitant to come forward. These are very hidden populations. They want to stay non-conforming and out of the mainstream. So to work alongside them is a privilege, but it requires a level of intense relationship that takes time and people. And those are the things that we appreciate that targeted support to be able to do.
Wonderful. There are a lot of amazing gems in this conversation. I want to thank you so much for your time today. And I'm very excited to see what comes out of your move to the next location, so that you're not all squished together in one little workspace.
We would love to share that. Thanks so much for your interest, Hilary.
Of course, I will definitely be speaking to you about that soon. Thank you again for your time today.
My pleasure.